I eliminated my evening hot shower routine 18 months ago after reviewing the cardiovascular literature on nocturnal stroke risk. My evening blood pressure readings dropped from an average of 138 by 86 millimeters mercury to 122 by 74 millimeters mercury within 3 weeks. My heart rate variability, measured via continuous monitoring, improved by 23% during the first 4 hours of sleep. I'm a professor of genetics studying metabolic regulation and cardiovascular aging mechanisms. Today, I'm sharing the precise physiological pathways through which common evening bathing practices may elevate nocturnal stroke risk, and the evidence-based protocol I now follow to protect cerebrovascular health during the critical overnight period. The nocturnal stroke phenomenon. Most individuals remain unaware that stroke incidence follows a distinct circadian pattern. Research published in Stroke demonstrates that ischemic stroke events cluster disproportionately during the early morning hours, between 4 o'clock a.m. and 8 o'clock a.m., with a secondary elevation during the late evening period. This timing correlates with specific hemodynamic vulnerabilities that emerge during sleep transitions. The cardiovascular system undergoes profound reorganization as we transition from wakefulness to sleep. Blood pressure normally decreases by 10 to 20% during the nocturnal dipping period, a protective mechanism that reduces cardiac workload and allows vascular repair. Heart rate declines, blood viscosity increases slightly due to relative dehydration, and autonomic nervous system balance shifts toward parasympathetic dominance. When this delicate orchestration becomes disrupted, particularly through thermal stressors applied immediately before sleep, the risk architecture changes substantially. The evening hours represent a critical window where preparatory behaviors directly influence overnight cardiovascular stability. Mechanism number 1: rapid thermal vasodilation and rebound vasoconstriction. The first mechanism involves the hemodynamic consequences of hot water exposure followed by rapid cooling. When hot water contacts the skin, typically at temperatures between 38 degrees Celsius and 42 degrees Celsius, 100 degrees Fahrenheit to 108 degrees Fahrenheit in most household showers, peripheral blood vessels undergo immediate vasodilation. This occurs through direct thermal effects on vascular smooth muscle and through activation of heat-sensitive transient receptor potential vanilloid (TRPV) channels in the vascular endothelium. Peripheral vasodilation causes blood to redistribute from the core circulation toward the skin surface. Cardiac output increases to maintain central perfusion. Blood pressure initially drops due to reduced systemic vascular resistance, a phenomenon called thermal hypotension. The critical problem emerges after exiting the hot shower. Ambient air temperature in most bathrooms ranges from 20 degrees Celsius to 24 degrees Celsius, 68 degrees Fahrenheit to 75 degrees Fahrenheit. This 15 to 20 degree temperature differential triggers rapid peripheral vasoconstriction as the body attempts to conserve core heat. Blood redistributes centrally. Systemic vascular resistance increases sharply. Blood pressure rebounds, often overshooting baseline values. Research from the Journal of Hypertension documented blood pressure increases of 15 to 25 millimeters mercury systolic within 10 to 15 minutes following hot water immersion and subsequent cooling. In individuals with existing endothelial dysfunction, atherosclerotic plaques, or impaired baroreceptor sensitivity, these rapid pressure fluctuations create mechanical stress on vulnerable arterial segments. Atherosclerotic plaques, particularly those with thin fibrous caps, experience increased shear stress during these pressure oscillations. The repetitive mechanical loading can contribute to plaque rupture or erosion, initiating the thrombotic cascade that underlies most ischemic strokes. I now maintain a maximum shower temperature of 35 degrees Celsius, 95 degrees Fahrenheit, warm enough for comfort, but below the threshold that triggers significant peripheral vasodilation. I installed a thermostatic shower valve with digital temperature display to ensure consistency. Mechanism number 2: nocturnal blood pressure pattern disruption. The second mechanism involves disruption of the normal nocturnal blood pressure dipping pattern. Healthy individuals exhibit a 10 to 20% reduction in blood pressure during sleep, classified as dipping in cardiovascular research. This nocturnal decline reduces cardiac workload, decreases shear stress on arterial walls, and creates a hemodynamic environment conducive to endothelial repair.
Non-dipping patterns, where blood pressure remains elevated or fails to decline appropriately during sleep, associate strongly with increased cardiovascular event risk. Research published in Circulation demonstrates that non-dipping elevates stroke risk by 20 to 30%, independent of daytime blood pressure values. Reverse dipping, where
Nocturnal pressure actually exceeds daytime values, carries even greater risk. Hot evening showers disrupt dipping through multiple pathways. The sympathetic nervous system activation required to manage post-shower thermal stress persists beyond the immediate cooling period. Catecholamine levels, including norepinephrine and epinephrine, remain elevated for 60 to 90 minutes following significant thermal challenges. These circulating catecholamines maintain peripheral vasoconstriction and elevated heart rate, impeding the parasympathetic dominance normally associated with sleep onset. Additionally, the thermal stress response activates the hypothalamic pituitary adrenal axis, elevating cortisol secretion. Cortisol, particularly when elevated during the evening hours, interferes with the normal circadian decline that facilitates healthy blood pressure dipping. Research in hypertension research documented impaired nocturnal dipping in subjects exposed to thermal stress within 2 hours of sleep onset. My protocol now includes concluding all hot water exposure at least 3 hours before sleep onset. I shower in the early evening, around 6 p.m., for a typical 10 p.m. bedtime, allowing adequate time for complete autonomic nervous system recovery. Mechanism number 3. Acute hemorrhagical changes. The third mechanism involves alterations in blood rheology, the flow properties of blood, that persist following hot water exposure. Hot water immersion induces sweating, leading to fluid loss that continues after shower completion. This fluid loss concentrates blood components, increasing hematocrit and blood viscosity. Research published in Thrombosis and Hemostasis documented increases in blood viscosity of 8 to 15% following 20 minutes of hot water immersion without adequate fluid replacement. Elevated viscosity increases resistance to blood flow, particularly through smaller cerebral vessels where flow rates are already slower. Simultaneously, hot water exposure activates platelets, the cellular components responsible for clot formation. Thermal stress triggers release of von Willebrand factor from endothelial cells and increases circulating levels of platelet-activating substances. Research in arteriosclerosis, thrombosis, and vascular biology demonstrated measurable platelet activation following thermal stress, with effects persisting for several hours. The combination of increased viscosity and enhanced platelet reactivity creates a prothrombotic state. During sleep, when physical activity is absent and blood flow velocity naturally decreases, this prothrombotic environment elevates the risk of clot formation, particularly at sites of pre-existing arterial narrowing or plaque formation. My countermeasure involves consuming 500 milliliters of water immediately following any warm water exposure, followed by an additional 300 milliliters before sleep. I avoid alcohol consumption, which exacerbates dehydration, on evenings when I shower later than usual. Mechanism number 4, impaired endothelial function. The fourth mechanism involves acute impairment of endothelial function, the regulatory capacity of the blood vessel lining. The endothelium produces nitric oxide, a critical vasodilator that maintains vascular tone, inhibits platelet aggregation, and prevents excessive smooth muscle cell proliferation. Healthy endothelial function provides continuous protection against thrombosis and inappropriate vasoconstriction. Rapid temperature transitions challenge endothelial adaptive capacity. Research published in Cardiovascular Research demonstrated that repeated thermal stress, particularly involving temperature oscillations, impairs endothelium-dependent vasodilation. The endothelium requires stable conditions to maintain optimal nitric oxide synthase activity and antioxidant defenses. Hot water exposure generates reactive oxygen species through several mechanisms, including mitochondrial stress in vascular cells and increased activity of NADPH oxidase. These reactive oxygen species consume nitric oxide directly and oxidize tetrahydrobiopterin, an essential cofactor for nitric oxide synthase, leading to enzyme uncoupling and reduced nitric oxide production. In the cerebral circulation, impaired endothelial function manifests as reduced capacity to dilate in response to metabolic demand and increased susceptibility to vasospasm. The middle cerebral artery, the vessel most commonly involved in ischemic stroke, demonstrates particular sensitivity to endothelial dysfunction. I support endothelial recovery through several interventions. I consume 1 gram of L-citrulline before sleep, a nitric oxide precursor that sustains nitric oxide availability through the overnight period. I maintain adequate vitamin C intake, 500 milligrams daily, to protect tetrahydrobiopterin from oxidation. I avoid hot water exposure within the 3-hour window before sleep, when endothelial recovery time would be insufficient. Mechanism number 5. Disrupted autonomic balance and arrhythmia risk. The fifth mechanism involves autonomic nervous system imbalances that persist following thermal stress. The autonomic nervous system regulates heart rate, blood pressure, and vascular tone through continuous balance between sympathetic, activating, and parasympathetic, calming branches. Healthy sleep transition requires a shift toward parasympathetic dominance, characterized by slowed heart rate, reduced blood pressure variability, and stable cardiac rhythm. Hot shower exposure immediately before sleep impairs this transition. The thermal stress activates sympathetic pathways that persist well beyond the immediate cooling period. Heart rate variability analysis, a measure of autonomic balance, demonstrates reduced parasympathetic activity for 90 to 120 minutes following significant thermal challenges. This sympathetic predominance carries specific arrhythmia risks. Research published in the European Heart Journal documented increased frequency of premature ventricular contractions and atrial ectopy during periods of elevated sympathetic tone. In individuals with underlying cardiac conduction abnormalities or subclinical arrhythmias, this autonomic imbalance may trigger sustained arrhythmias. Atrial fibrillation, an irregular heart rhythm originating in the upper heart chambers, carries substantial stroke risk due to blood stasis and clot formation in the left atrial appendage. Hot water immersion has been documented to trigger atrial fibrillation episodes in susceptible individuals. Research in circulation, arrhythmia, and electrophysiology demonstrated that thermal stress, both heat exposure and rapid cooling, represents a recognized trigger for paroxysmal atrial fibrillation. My evening routine now includes specific parasympathetic activation techniques. I practice slow diaphragmatic breathing, 5 to 6 breaths per minute, for 10 minutes before sleep, a pattern shown to enhance vagal tone and restore autonomic balance. I monitor my heart rate variability using a wearable device, confirming adequate parasympathetic recovery before sleep onset. Mechanism number 6. Cerebral autoregulation impairment. The sixth mechanism involves transient impairment of cerebral autoregulation, the brain's capacity to maintain stable blood flow despite fluctuations in systemic blood pressure. Under normal conditions, cerebral blood vessels dilate or constrict to buffer blood flow against pressure variations. This protective mechanism ensures consistent oxygen and nutrient delivery to brain tissue across a wide range of physiological conditions. Research published in Stroke demonstrates that thermal stress temporarily impairs cerebral autoregulation. The mechanisms involve both direct thermal effects on cerebral vascular smooth muscle and systemic factors, including altered carbon dioxide levels, which profoundly influence cerebral vascular tone and circulating stress hormones. During the period of impaired autoregulation, cerebral blood flow becomes more pressure-dependent. The blood pressure oscillations induced by post-shower thermal transitions translate more directly into cerebral blood flow fluctuations. In brain regions with marginally adequate perfusion, such as watershed zones between major arterial territories, these fluctuations may produce transient ischemia. Additionally, impaired autoregulation increases the brain's vulnerability to embolic events. Under normal conditions, cerebral vessels can partially compensate for transient flow reductions by dilating downstream segments. When this compensatory capacity is impaired, small emboli produce larger ischemic territories. The autoregulatory system typically requires 60 to 90 minutes to recover following significant thermal stress. My protocol ensures this recovery period occurs before sleep onset, when blood pressure naturally decreases and the demands on autoregulatory systems intensify. Mechanism number 7. Interaction with cardiovascular medications. The seventh mechanism involves potentially dangerous interactions between thermal stress and common cardiovascular medications. Many individuals at elevated stroke risk take antihypertensive medications, drugs that lower blood pressure through various mechanisms, including vasodilation, reduced heart rate, and decreased fluid volume. Hot water exposure amplifies the blood pressure-lowering effects of these medications. Beta blockers, which reduce heart rate and cardiac output, combined with thermal vasodilation, may produce excessive blood pressure reduction, leading to cerebral hypoperfusion. Research published in Hypertension documented cases of syncope, fainting, and pre-syncope in patients taking antihypertensive medications following hot bath immersion. Calcium channel blockers, another common antihypertensive class, directly enhance vasodilation, compounding the thermal effects. Diuretics, which reduce blood volume, exacerbate the dehydration effects of sweating. ACE inhibitors and angiotensin receptor blockers, which affect vascular tone regulation, may impair the compensatory responses necessary to maintain cerebral perfusion during thermal transitions. The interaction extends to anticoagulant medications. Warfarin metabolism demonstrates temperature sensitivity. Hot water exposure may transiently alter the INR, International Normalized Ratio, that determines bleeding and clotting risk. Research in thrombosis research suggested that significant thermal exposure can influence coagulation factor activity in patients on vitamin K antagonists. I recommend that individuals taking cardiovascular medications discuss evening bathing practices with their prescribing physician. For my own protocol, though I do not take antihypertensive medications currently, I maintain awareness that medication interactions amplify the risks associated with thermal stress. Based on these mechanisms, I developed a comprehensive evening bathing protocol that eliminates unnecessary risk while maintaining hygiene and comfort. Timing protocol. I complete all warm water exposure at least 3 hours before intended sleep time. For a 10 p.m. bedtime, my shower concludes by 7 p.m. This timing allows complete recovery of autonomic balance, endothelial function, and cerebral autoregulation before sleep onset. Temperature protocol. Maximum water temperature is 35 degrees Celsius, 95 degrees Fahrenheit. Warm enough for comfort, but below the threshold, triggering significant peripheral vasodilation. I verified this temperature using a digital thermometer and subsequently installed a thermostatic mixing valve, providing consistent temperature control. Duration protocol. Total warm water exposure remains under 10 minutes. Prolonged exposure amplifies all the mechanisms I described. Greater fluid loss, more pronounced platelet activation, and more substantial autonomic disruption. Transition protocol. I avoid rapid temperature transitions. After warm water exposure, I remain in the warm bathroom environment for 5 minutes before moving to cooler ambient temperatures. This graduated transition reduces the rebound vasoconstriction that elevates blood pressure. Hydration protocol. I consume 500 milliliters of room temperature water within 30 minutes following any warm water exposure. An additional 250 to 300 milliliters follows approximately 60 minutes later. This replaces fluid lost through sweating and maintains optimal blood viscosity. Autonomic recovery protocol. If circumstances require showering closer to bedtime than my preferred 3-hour window, I practice 10 minutes of slow diaphragmatic breathing, 5 to 6 breaths per minute, before sleep. Research in psychosomatic medicine demonstrates this practice enhances parasympathetic activation and improves heart rate variability, partially compensating for the autonomic disruption of thermal stress. Supporting interventions. Several additional interventions support cerebrovascular protection during the overnight period. Omega-3 fatty acids. I consume 2 to 3 grams of combined EPA and DHA daily. The marine omega-3 fatty acids, documented to reduce blood viscosity, decrease platelet aggregation, and improve endothelial function. Research published in Atherosclerosis demonstrated that omega-3 supplementation reduces blood viscosity by 4 to 8% within 8 weeks, partially compensating for viscosity increases following thermal stress or overnight dehydration. Magnesium. I take 400 milligrams of magnesium glycinate with my evening meal, approximately 4 hours before sleep. Magnesium supports endothelial function, reduces vascular smooth muscle contractility, and enhances parasympathetic nervous system activity. Research in hypertension documented blood pressure reductions of 5 to 7 mRg systolic with adequate magnesium intake. As mentioned, I consume 1 gram of L-citrulline approximately 2 hours before sleep. L-citrulline converts to L-arginine in the kidneys, providing sustained substrate for nitric oxide production through the overnight period. Unlike direct L-arginine supplementation, which is extensively metabolized during first-pass liver processing, L-citrulline achieves superior bioavailability for nitric oxide support. Coenzyme Q10. I maintain 200 milligrams daily of ubiquinol-form coenzyme Q10. This mitochondrial cofactor supports endothelial cell energy production and functions as a lipid-soluble antioxidant, reducing the oxidative stress that impairs endothelial function following thermal challenges. My measured results. After implementing this protocol consistently for 18 months, I documented the following improvements. Blood pressure. Evening blood pressure readings decreased from 138 over 86 millimeters of mercury average to 122 over 74 millimeters of mercury average, a reduction of 16 millimeters of mercury systolic and 12 millimeters of mercury diastolic. Learning readings, previously elevated at 145/88 mmHg, now average 126/78 mmHg. Heart rate variability. My RMSSD, root mean square of successive differences, a measure of parasympathetic activity, increased from 28 milliseconds to 41 milliseconds during the first 4 hours of sleep. This 46% improvement indicates substantially better autonomic balance during the critical early sleep period. Blood viscosity indicators. My hematocrit remains stable at 44% despite eliminating significant pre-sleep dehydration. Fibrinogen levels, a blood viscosity determinant and independent cardiovascular risk marker, decrease from 385 mg DLO to 318 mg DLO over the monitoring period. Sleep architecture. Continuous monitoring revealed increased deep sleep duration from 58 minutes average to 79 minutes average, a 36% improvement. Deep sleep represents the period of maximum parasympathetic dominance and cardiovascular restoration. High sensitivity C-reactive protein, a systemic inflammation marker associated with cardiovascular risk, decreased from 2.1 milligrams per liter to 0.8 milligrams per liter. This reduction likely reflects improved endothelial function and reduced chronic vascular stress. Frequently asked questions. Q. Can cold showers before bed also increase stroke risk? A. Cold water exposure carries different but potentially overlapping risks. Cold water triggers immediate vasoconstriction rather than vasodilation, rapidly increasing blood pressure and cardiac workload. Research in circulation documented blood pressure increases of 20 to 40 millimeters of mercury systolic following cold water immersion. For individuals with compromised cardiovascular systems, either thermal extreme before sleep represents a potential risk. I recommend temperate water, around 32 to 35 degrees Celsius, that's 90 to 95 degrees Fahrenheit, for evening bathing. Q. Is morning hot showering safer than evening? A. Morning hot showers occur during a period when cardiovascular risk is already elevated. The early morning surge in blood pressure, heart rate, and platelet activity represents the highest risk period for cardiovascular events. However, the body's compensatory mechanisms are generally more robust during waking hours when sympathetic activation is appropriate. The evening period, when the body attempts to transition toward parasympathetic dominance, may be more vulnerable to disruption. I recommend moderate temperatures for showers at any time. Q. What about hot tubs or bath immersion? A. Full-body hot water immersion amplifies all the mechanisms I described. The greater surface area involved produces more substantial vasodilation, more significant fluid shifts, and more pronounced autonomic effects. Research in QJM, an international journal of medicine, documented multiple cases of stroke and sudden cardiac death temporally associated with hot tub use. I avoid hot tubs entirely and limit bath immersion to temperatures below 37 degrees Celsius, 99 degrees Fahrenheit, with durations under 15 minutes, never within 3 hours of sleep. Q. Do these risks apply to younger individuals? A. While cardiovascular event risk is substantially lower in younger populations, the physiological mechanisms operate at any age. Younger individuals generally possess more robust compensatory mechanisms, better baroreceptor sensitivity, more elastic blood vessels, more resilient endothelial function. However, undiagnosed congenital cardiac abnormalities, unrecognized hypertension, or other occult cardiovascular conditions may render certain younger individuals vulnerable. I recommend the protective protocols regardless of age. Q. What signs indicate I may be especially vulnerable? Particular attention to evening thermal stress is warranted for individuals with existing hypertension, diabetes, atrial fibrillation, or other arrhythmias, prior stroke or transient ischemic attack, significant carotid artery disease, chronic kidney disease, or family history of early cardiovascular disease. Additionally, individuals who notice lightheadedness after hot showers, post-shower headaches, or palpitations following thermal exposure may possess heightened vulnerability. Concluding perspective: the relationship between evening bathing habits and nocturnal stroke risk illustrates a broader principle in cardiovascular medicine, that seemingly benign daily practices can carry significant physiological consequences when examined through mechanistic understanding. The 7 mechanisms I outlined: rapid thermal vasodilation with rebound vasoconstriction, nocturnal blood pressure dipping disruption, hemorrheological changes, endothelial dysfunction, autonomic imbalance, cerebral autoregulation impairment, and medication interactions, represent modifiable risk factors within individual control. My protocol: showering at moderate temperatures at least 3 hours before sleep, maintaining adequate hydration, supporting endothelial function through targeted supplementation, and ensuring autonomic recovery before sleep onset, addresses each mechanism systematically. The measured improvements in my evening blood pressure, heart rate variability, sleep architecture, and inflammatory markers provide objective confirmation that these interventions produce physiologically meaningful effects. The 16 millimeter of mercury reduction in evening systolic blood pressure alone, if maintained over years, substantially reduces cumulative stroke risk based on epidemiological data. I encourage viewers to evaluate their own evening bathing practices through this mechanistic lens. Small modifications, adjusting temperature, timing, and hydration, require minimal effort, while potentially providing substantial cardiovascular protection during the vulnerable overnight period. I'm a professor of genetics, studying the intersection of metabolic regulation and cardiovascular aging. The cardiovascular system, like all biological systems, responds to environmental inputs in predictable ways. Understanding these responses empowers informed decisions that support long-term health.